Good afternoon, everybody, and welcome to our Carefinder industry briefing, which is RFP 134. Today, we'll go through the information slides and then take any questions towards after we've completed the information slides. We know that a lot of you here today are new service providers, so we just thought we'd provide a little bit of background information about who is the Hunter New England Central Coast Primary Health Network. We are a not-for-profit organisation primarily funded by the Commonwealth Government through the Department of Health and Aged Care. We aim to improve the efficiency and effectiveness of the primary healthcare system by commissioning services. We service a region that's vast in geographical terms and diverse in terms of communities. The region encompasses 130,000 square kilometres of New South Wales, reaching from the Queensland border in the north to the Hawkesbury River in the south and west past Narrabri and Moree. The area has a population of over 1.2 million people who live in small, rural and remote communities, in regional towns and in densely populated urban centres. The core business of the Hunter New England Central Coast Primary Health Network is guided by the quadruple aim framework for optimising the health of individuals and populations, the components of which include improving population health outcomes, improving the patient experience, providing value for money, and improving the care and experience of the provider. In particular, value for money requires competitive and non-discriminatory processes, using resources in an efficient, effective, economical and ethical manner, non-duplication of other entities, accountable and transparent decision-making, managing risk and conflict of interest, and process is commensurate with scale and scope. Disclaimer. Potential respondents should make their own assessment of a decision to submit a proposal and seek independent business advice if necessary. This slide pack provides information only. No statement varies the request for proposal unless confirmed through an addendum. All addendum will be communicated to all potential respondents. Our probity principles. The Primary Health Network staff will only interact with potential respondents as part of business as usual functions. Respondents must not seek to elicit or obtain RFP information from PHN staff. Respondents found to be in breach may be excluded from the RFP process. All respondents will receive the same information at the same time via TenderLink. The TenderLink online portal and online forum are the means of communication during the RFP process. The tender process and key dates are as here outlined on the screen. Request for proposal issued on the 29th of August. Request for proposal closes at 10 a.m. Monday the 26th of September 2022. Request for proposal evaluation will be September to October 2022. Our shortlisted interviews will take place between the 18th and the 20th of October 2022. The contracts will be executed by the 23rd of December 2022. The services will be established between the 1st to the 31st of March 2023. The services will commence and be operational by the 1st of April 2023. The Carefinder program. The purpose of the Carefinder program is to provide specialist and intensive assistance to help people understand and access aged care and connect with other relevant supports in the community. The target population is people who are eligible for aged care services and have one or more reasons for requiring intensive support to interact with my aged care and/or access relevant supports. The target population age range is those 65 years or older and 50 years or older for First Nations people, or 50 years or older or 40 years or older for First Nations people on low income and homeless or at risk of being homeless. Reasons for requiring intensive support. Carefinders will complement and should not duplicate the My Aged Care channels that provide access support to people who are able to proactively navigate the system for themselves. Carefinders will therefore specifically target senior Australians who need intensive support. Reasons for requiring the intensive support may include isolation or no support person, for example, a carer, family or representative, who they're comfortable to act on their behalf and or who is willing and able to support them to access aged care services via My Aged Care. It also may include people with communication barriers, including limited literacy skills or difficulty processing information to make decisions. Intensive support may also be for people who have resistance to engage with aged care for any reason, and their safety is at immediate risk, or they may end up in a crisis situation within approximately the next year. Or those who have past experiences that mean they are hesitant to engage with aged care or institutions or government. The model of care be predominantly face-to-face service delivery, conscientious carer workforce, assertive outreach to find and connect with target populations, knowledge of community available services, and established relationships and partnerships with intermediaries. Receipt and management of incoming referrals, actively participate in the Hunter New England Central Coast Carefinder community of practice, and provide monthly reporting via online data portal. Case studies for our Carefinder functions can be found at the back of the Carefinder policy guidance document, attachment 6 of the tender package. Conflict of interest and ethics in service delivery. This includes any activity or obtaining any interest that is likely to conflict or restrict the Carefinder organisation in delivering Carefinder services fairly and independently. Organisation and individuals must respect and facilitate optimal choices for clients. No corporate or other relationship between the Carefinder organisation and other organisation will influence, impact or restrict this choice due to an actual, potential or perceived conflict of interest. We must not receive any financial benefit, sometimes referred to as a finder's fee, as a result of referring a Carefinder client to a service and or service provider. Will be required to report when Carefinder clients are referred to their own organisation and that choice was offered where available. The key documents as part of your RFP package included Segment A, the conditions of proposal. Segment B, Hunter New England Central Coast standard terms and conditions of contract departures. Segment C, scope of services. Segment D, returnable schedules and attachments. 1, workforce template. 2, implementation plan template. 3, cultural safety template. 4, risk and governance template. 5, tender pricing responsible template. 6, Carefinder policy guidance for PHNs. And 7, evaluation of the Carefinder program summary evaluation plan. Communication protocol and lodgement. Asking questions. Questions, please provide them in writing through the online forum icon in the TenderLink website or via the link in the TenderLink portal. Select tender, post a new question. Tenders will be lodged at tenderlink.com/HNECCPHN/. Any technical questions, please provide them to the number listed and or via the email. Thank you for attending and listening to our information slides. We'll now go to any questions that may be within our question box. Please use the questions box through the GoToWebinar platform to submit any questions that we can consider for answering today. First question we have received here today is the PHN able to provide further detail on the expected number of participants for each LGA or the region as a whole? We have Jocelyn Carston here available in the room with us. Jocelyn, are you able to answer this question?
Yeah, sure. So the PHN does not have an expectation of number of participants. Respondents are required to estimate service delivery activities as outlined in Attachment 5, Proposal Pricing Response Template, in hours and months and by FTE.
Thanks, Joce. Second question we have here is there any additional information you can provide on the demand for the service? Joce?
Yeah, so we're not providing participant numbers or the quantum of funding available. We are hoping that respondents are going to use their local knowledge and experience within their existing service delivery to estimate their service delivery activities and detailed expenditure costs, and therefore the demand of the service.
Rebecca, it's Catherine. Can I jump in?
Catherine, did you want to add to that?
Yes, if I may. Hello, everyone. It's Catherine Turner here, the Exec Manager for Commissioning. Whilst just to fill out a little bit more information to Jocelyn's response there, there is some information on the PHN website that relates to population numbers, which might be helpful for people who don't have that information themselves. So if you have a look on our website, under, I think it's under planning or commissioning, but there's definitely some information there about that might help with some demographics when trying to get some assessment if that's information that people need that they might not have been able to access before.
Thank you, Catherine. The next question is there any guidance on financial models and expected contract amount?
No, at this stage, we're not putting out a amount that we're going to spend on this program. Again, we're looking to see what comes in and what the service providers believe the needs are within the local community.
The next question we have here, how does Carefinder compare to RAS? Will non-current RAS providers have a good chance of being awarded this contract?
I think we'll take that one on notice and get back to you with a considered response in the addendum that comes out through Tenderlink, unless, Catherine, that you would like to add anything there.
Yeah, hi Jocelyn. Because this is actually a new program that has some similarities to other programs, we're really interested in hearing from all and sundry, I suppose. We want to make sure that we have the right service available, the best service available for people right across the region, which is quite diverse. So yes, we are certainly not under any obligation to existing service partners that for other programs, and this is a new program, but we will put a response out about the specific differences between the two programs, or some of, not all of them, obviously, but we'll put a more considered response out as an addendum. Thanks, Beck.
The next question here is, do you have an expectation of FTE, please? With such a varied population in the PHN catchment, can you advise on what your expectation is within the smaller LGAs?
Yeah, really good question. I do sound like I'm repeating myself, I think, here, but really look at your target population. It is a pointy end service. It is trying to reach those that are not being serviced or fit within those criteria about needing intensive support. So in the smaller LGAs, I encourage you, if you know your community, to really know how much that might be FTE wise to support those people, given that there will be a spread across the large H&E area.
Thank you to everyone for your questions so far. We still do have a short amount of time if anyone wanted to submit any more questions. We'll just give it another couple of minutes for those final questions to come through.
I was just wondering if it might be just worth going over what we perceive to be the definitions for service delivery and assertive outreach, which will assist you in developing your model of care, but also filling in the pricing template. So the service delivery definition is that hours worked to provide direct and indirect support to a client. And that's engaging and building rapport, support to interact with my aged care, supporting them through the assessment process, support to find aged care supports and services, undertaking those high-level check-ins, as well as indirect supports, just such as doing your background research on potential providers before you see a client, as well as the travel to and from meetings. So anything that you're doing with or for or on your way to do with a client. That's separate to what we mean by assertive outreach. So what we're deeming when we're saying assertive outreach is the hours worked to undertake those activities as defined, and it does define it quite well under the policy guidance document on page 12. And it's those activities to proactively identify and engage with people in the Carefinder target population. And these activities can be face-to-face or phone-based, collaborative Teams meetings, and the hours taken to travel to these associated assertive outreach activities. So hopefully that provides a bit of clarification for that pricing template.
Thank you everyone for attending again. We seem to have no further questions today. If there are any questions come through, please feel free to type them. And if they pop up before we end, we'll get to those. In the meantime, I'll just let you know that everyone will receive a copy of the slides that have been shown today, the recording of this session, and a formal response to all of the questions will be provided by an addendum. If there are no further questions today, we will wrap this up. But please, if you do have further questions, you can provide them, as the slide says, through Tenderlink, which will be responded to in a timely fashion and sent to all tenderers. There have been no further questions, so we'll wrap up today's session. Thank you again for attending, and we look forward to liaising with you further through the Tenderlink portal. Thanks so much. Bye.
Thanks, Rebecca.